Today's conversation is going to be great. We're really looking forward to it. These people have had conversations before, and we went more than an hour just chatting away and found a lot of common ground between the organizations and the people that you'll be hearing from. This is going to be a conversation about the center that Dr. Alberti Philip, we'll call him, who is the founding director of AAMC's Center for Health Justice, which aims to address health inequities, improve community health across the United States. Interestingly enough, Philip was involved prior to this, before joining AAMC in 2012. He led a research, evaluation, and planning efforts for a bureau within the New York City Department of Health Mental Hygiene that works to promote health equity between disadvantaged and advantaged neighborhoods. He is not new to the area of health equity. I also want to introduce my colleague, Pamela Bronner-White, the Chief Diversity, Equity, Inclusion Officer and Senior Vice President of Communications at ABIM and the ABIM Foundation. She has served more than 25 years in communications, public affairs, community relations, and strategic development, and has probably met all the famous people in the world, or at least the United States, at one time in her life.
Great introduction. And Daniel's not only a colleague, but also a friend. And I'm so glad to be here with you, and especially with you, Philip. It's just really exciting to be able to have this conversation. We've already met, we talked for a long time, so I'm absolutely in awe of the work and just what your work represents. But I also thought it would be fitting for us to start out with, since we're on the back end of the Martin Luther King's birthday and a day of observance, to share a quote and to hear a little bit from you about how the MLK, his message, his words, how it's shaped your life. And we're going to talk a lot today about words and their meanings. So this was a quote from Dr. King in 1966, when he was giving a speech to the Medical Committee for Human Rights. And he said, "Of all forms of discrimination and inequalities, injustice in health is the most shocking and inhumane."
Yeah.
And here we are 55 years later, having some of the same conversations.
Yes.
In some places in our communities, in some segments of our communities, it's much worse than it was even then.
Yep.
So share with me just a little bit about how MLK impacted your life and the work that you've been involved in.
Sure. Well, first, thank you, Pamela and Daniel, for the introduction and the opportunity to be here and have this conversation today. You know, that quote that you read, Pamela, is kind of always front and center and top of mind. And I think those of us that are in the health equity, health justice space feel that in our bones. I think in addition to that quote, which is always, like I said, kind of emblazoned just at the tip of my brain, I think one of the things that I have always found so inspirational of Dr. King's writing and leadership is how bold he was in tying together racial, economic, and political injustice. That the agenda was so broad and really so deep and really underscored the purposeful way in which those injustices are tied together in our society. And so the thought of thinking, you know, I came up in the social conditions as fundamental causes of disease kind of framework in public health. And that's where that quote really hits me hardest, is really understanding that if we are going to be successful, if we are going to make sure that there's progress in the next 50, 100, 150 years, it has to attack injustice on all fronts, racial, political, and economic. And so that's a lesson that I think that I and the center carries forward.
Thank you. You know, as I think about the work that you've done and the work that you're involved with, you have to be somewhat of an optimist to be doing this work for so long, given the history of our country and how difficult it is for us to even have the conversation I remember back in Philadelphia at the National Constitution Center when Obama was running for president, actually, and he said, in all of these years, we still haven't been able to have the conversation. So tell me a little bit about your history, about yourself that has you involved in this work and has you optimistic that you can still dig in and do what you do.
I will do that. I'll be honest, Pamela, it is not something that is easy and comfortable for me or anyone to talk about myself, I'll put it that way. But I agree, it is, unless you have a personal connection, I talk about this with my friends and my colleagues all the time in this work specifically, unless there's a clear personal motivating connection factor, it really is hard to stay optimistic. And I think for me, that personal connection, kind of a little bit of nature and a little bit of nurture, I guess, so to speak. So on the nature side, and this, I've told this story before, but it might sound, I don't know, silly or trite or something, but I have vivid memories of being a really young child, 5, 6 years old, my son's age, and being literally physically incapable of sitting through any entire episode of The Roadrunner, for example, because the laws of physics only applied to the coyote. I couldn't bear it. I couldn't stay in the room. It just wasn't fair to me. Again, maybe a silly thing, but there's something in me that has always been just very hardwired to react in a physical way to anything that I perceived as unjust or unfair. But you can't really talk about the personal connection unless we get a little personal. So on the nature side, so here's who I am and how I approach this work. So I am first generation high school on my dad's side. He was a Sicilian barber, and first generation college on my mom's side, Russian Jew homemaker. I'm a gay man. And so those issues of class and sexual orientation are kind of how I enter the space in this work. And despite, I would say, maybe the barriers that you would think kind of were erected in front of me because of some of those demographics, right? The class, working class, definitely not economically privileged. Certainly no one in my family had any idea of what graduate school would be. Despite all of that, I was privileged enough to find myself at some of the best the best schools in Boston where I grew up, and then later high school and college. And I think, in middle school, in late elementary school, we students kind of divided ourselves in this privileged place by class. And we know that in America, class and race are highly correlated. And so for 5th, 6th, 7th, 8th grade, I was part of a very tight, very diverse, kind of the only white kid in the circle, learning lessons in real time together about classism and racism, learning personal lessons of homophobia that I couldn't at that time share with anyone else. And I think those experiences infuriated me as much as or more than the Roadrunner did. And then I think the seminal moment for me when that kind of passion crystallized into commitment was in high school. So I attended kind of one of the most privileged high schools you can imagine, great school, but I mean privilege like oozing from every pore, every hallowed hall. And I can remember super early on, first year, 14 years old, all school assembly, one of the very first, Peggy McIntosh, an incredible activist and writer, came to speak about unpacking the invisible backpack of white privilege. And for me, given that instinct and all the experiences that I just had as a young middle schooler, I was just on the edge of my seat, so engrossed in what it meant and the examples, some of which I was aware of and some of them I never even had thought of. And I remember looking around at all of my new friends who were literally the most privileged folks, like that whose parents and families could pull all the levers, right? All of them. And like none of them were listening. And I think for me, it kicked me over that edge to hear something that I care a lot about, to hear something that I really want to commit myself to. And today, I mentioned I have a son. He is multiracial, multi-ethnic. He's going to be 6 years old in April. And so that just adds a whole other layer of personal connection in a different way, a deeper way, to feel afraid, to feel infuriated, to feel motivated, to really make progress in this space for him and for the generations to come. So it's kind of a layer of nature and nurture for me.
Well, thank you. Yesterday we had a celebration observance for MLK, and we asked several of our colleagues to share about themselves and about the perspective. And I think it's incredibly generous of you to share with more than 200 of people that
I'm
you
not
don't
looking
even
at the
know.
number. I'm not
Sorry,
looking
don't
at
look at the number, but it's not always easy to share who you are. And I just wanted to thank you for your generosity of spirit in sharing that information. So when we talk about trust, though, it's like you trust who you know, right? You trust people who have an interest in you. And so thank you, because I feel like you've shown some trust in me here. So tell us about how you came to the Center for Health Justice.
Sure. So as Daniel mentioned, I joined the AAMC, it'll be 10 years ago in March as the Senior Director for Health Equity Research and Policy. And a lot of that work kind of laid the foundation for the center. So the center is an outgrowth of the AAMC's strategic planning process, which was initiated by our president and CEO, Dr. David Skorton, just about two and a half years ago. And it was a really beautiful, kind of broadly engaged process. We received, I think, thousands of pieces of input and data and information from our member medical schools and teaching hospitals. We had kind of like internal Shark Tank for the AMC staff ourselves, where we could propose and pitch ideas about what we thought were the most important priorities for the organization. And so through that kind of year-long process, 10, we call them action plans, 10 action plans surfaced. And Action Plan 9 is the AAMC Center for Health Justice. And so at its core, the goal is health equity, and we really believe the path to health equity is health justice. And I can add a little definition there. I'm an epidemiologist, I love definition. So we talk about health equity as being a place where every community begins at the same starting line for health. And I think that definition is important for us for two reasons. One, it keeps our eyes on the community, right? Health inequities are population dynamics. You know, patients don't have health inequities, your friends don't have health inequities, but their neighborhoods, their communities do. And so it really gives an important direction for the kinds of interventions that are going to be successful. And I think the other part that's really important is that it's about the same starting line for health and not the same endpoint for health. Right? Equity is about opportunity. It's not about mandating that all groups have the same outcomes. It's about doing our best to ensure that we all have the same resources, the same tools, so we can be as healthy as we can be. And so if health equity is the goal, we think health justice is the path. And very simply put, I didn't come up with the health justice framework. I want to give a shout out to Emily Benfer, who's an incredible lawyer, wrote a paper in 2015 laying it out, and there was a revision just last year. But the way that we operationalize health justice is one foot in community wisdom, the other foot in a research to action imperative, and then both feet walking down that street in a very clear anti-racist and anti-discriminatory way. So that's how we kind of organize the law and policy agenda of health justice for the center and for the AAMC.
I have to say this, and I was really believing in community wisdom is so important. We're not going to fly in and save people. There is a great wealth of information and wisdom from the community. They know a lot.
Yes.
And it's really interesting to me to think about what the conversation, when you started this, what the conversation looked like then. And then we had June of 2020 happen, and it felt like the whole world just blew up.
Yep.
For all of us, for whatever background that you were. Talk to me a little bit about how the conversation, I wouldn't even say shift, I think it was just a whole new paradigm. Talk to me a little bit about that.
My goodness. Well, I think first, for many of us that have been in health equity broadly, social justice broadly for decades, it was beautiful, I think, to see so much new work, new attention, new focus, new mandate, new directive, even though it was born from devastation, right? Pandemic devastation, racial injustice devastation, but still from that came this optimism. Pam, I'm so glad you started with this, because you have to be optimistic. So it's a moment to seize that those opportunities that were newly online and the attention that was focused. But it's also a really perilous moment, because there's new work that wasn't necessarily standing on the shoulders of community wisdom. that wasn't necessarily trying to do the authentic. And it's interesting, you mentioned June of 2020. That time frame is exactly when the center's principles of trustworthiness were born. And so the most clear kind of like professional reaction to March through June of 2020, July, August of 2020, was this effort to develop these 10 principles that I'm sure we'll talk about in a little bit.
In just a minute, yeah, we will. And it's interesting, the idea of trust. So for ABIM, for example, the whole world just kind of blew up for us like it blew up for everybody else. And we were having conversations about diversity, equity, and inclusion work. And as a person who's been involved in the corporate sector before coming to ABIM, I have been running away from DEI because I thought it was really important that, and a liberty to not always be the Black person in the room, but that my profession that I could have a profession.
Right.
And that I didn't always have to carry that. And not that I didn't want to carry it, and not that I didn't think it was important, and not that I don't bring it to me, to my work and what I do every single day. But I also felt that it wasn't time. Like 85 wasn't the time. 1990 wasn't the time. If you looked at leadership of many organizations, it wasn't the time to do that. I thought the work and the effort would be marginalized. And so this was the time for me to say, with all the confluence of activity that's happening with the organization that I'm with and how important health equity is, I felt it was time to kind of step up. And I remember our reaction to police brutality and just really having a very honest conversation within our organization about, it's not just police brutality on Black and brown bodies. It's also, if we look at healthcare and how communities felt. In my community, it was, I'm not getting surgery. Once you get surgery, it's all over. I'm not going to the doctor. I have some home remedies, and everyone sits around and shares the home remedies because there was never trust.
That's right.
And so talk to me a little bit about that idea of trustworthy principles and who they were targeted to and where you are now.
So I also just want to, you sparked something else for me, and I really will get to the principles, but you talked about kind of equity. And I think we're also in this moment of figuring out where the work lives, where it's complementary, and the distinctions, right? So I've really become enamored of thinking about equity in three ways, right? So there's kind of organizational equity, much of the work that you just described. How do we create inclusive environments that really create opportunities for promotion, for tenure, for well-being of staff, of faculty, of learners, if we're thinking about medicine. And I think there's patient healthcare equity, right? How do we create that equity of opportunity for our patients, and the kind of trust that requires to make sure that any patient population has equitable access, equitable quality. And then there's this even larger conversation about the kind of equity that we want to build in and with our communities, right, for kind of health generally. And I think the principles of trustworthiness apply across kind of all three levels of those of equity. And I would have to say these principles are certainly one of my kind of proudest, I think, professional achievements, not just because of what they are, but because of how we put it together. So I'll give you just like 2 minutes of history to kind of put these principles in context. So for many years, 4 or 5 years, our health equity research and policy team had developed what we called community engagement toolkits. So wherever our annual meeting was going to be held, whatever big city, we would reach out a year in advance to our members there and say, we're really interested in engaging with your local community members to understand issues of social and health injustice of import to them. We want to work with you. We want to video record them, invite them to our session, help them lead a conversation with our community about what academic medicine can do to meet their needs, whatever they might be. And so we had some really successful previous toolkits. In 2020, we were going to be in DC. We had planned to do veterans health equity was going to be our focus. And then, of course, as you said, the world blew up. And we heard, our team heard in the news, lots of conversations about trust and lots of conversations about community. This is just about the time that the clinical trials were starting up. And we heard a lot of physicians and public health scientists and government spokespeople talk on behalf of communities, talk about what communities needed. We didn't really hear a lot of actual community voice. And we also heard in the framing of the conversation, kind of, oh, if only they would trust us, right? If only the community had that pamphlet, that magical pamphlet that was going to kind of educate them, and then we'd just be done with all this and we could move forward and you know, COVID's no more. And I think for our team, we were just infuriated. I keep using that word. We were infuriated. It wasn't the right framing because the onus is on us, right? Organizations like academic health centers, like medical schools with power and privilege, the onus is on us to demonstrate that we are worthy of trust. If you can do that, then trust will come, then the beneficial outcomes will come. It's not about convincing or strong arming communities to finally believe us, right? So we really felt an imperative to do a different kind of work. I'm sorry, please.
No, I was just agreeing with you and just kind of thinking about what does that look like?
And so here's what we did, and time will tell whether we, you know, did it right. So we convene a group called AAMC Charge, which is our Collaborative for Health Equity, Act, Research, Generate Evidence, kind of a tortured acronym, but works for us.
They all are.
So we put out kind of an all points bulletin. We said, who in charge? So it's about 1,200 folks from across the country, health equity champions. You know, only 60% are from an academic health center. The other 40% are their public health partners, community partners, business partners, government partners. And we said, who has qualitative experience? Who has interview experience, videography experience? And so we worked with 9 members from Charge, representing 7 different geographies across the US. Kind of the first step was, how do you innovate community engagement during a time of social distancing? So that was a challenge. How do we do Zoom interviews? How do we convince IRBs to accept digitally signed consent forms? But then we sorted all that out. And then each of those Charge collaborators interviewed 3, 4, 5 local community members. And then that full collective, so all 50 of us, the Charge members, the center, and all the interviewees dove into 30 hours of video footage, right? Extracted these 10 principles, extracted the action steps, because the toolkit isn't just these 10 kind of pithy statements. It's also an action guide on what organizations and people can do to show they're walking the walk on those principles. It's a reflection guide to take a pause and really think back about how you come at those principles and those skills. And all of us develop that together. And so we often say, you know, in our center that the process is as important as the product. And I really think that's true when it comes to trustworthiness. When it came to this toolkit, that's why the tone is different, the voice is different. It's how can a national organization like the AMC Center for Health Justice be a true, authentic conduit for that community voice, for that community wisdom. And that's how that came to be.
Is there part of, do you have to look the same? Do you have to sound the same? I mean, when you're talking about these, and you can give us a couple of examples of the tenets, the principles, what is the connection? What is the active connection to make people feel like I can listen and I can believe what I'm hearing?
So the first principle, I have a couple that are favorites. The first principle is the community is already educated, right? That's why it doesn't trust you. And so I think there are a couple of things to unpack in that and to reflect on. So one, there's a history, right? There's a history between your organization and your community that you must accept, acknowledge, understand the ramifications, and then work to undo. You know, and the second thing is the importance of language, right? Don't come at us saying you just have to be educated, right? That's putting the burden, the onus, the deficit on the community. Let's talk about partnership. Let's talk about collaboration. Let's talk about efforts that your organization and communities can co-design. It's a different frame. It's a different way of thinking about the relationship and talking about the relationship. And so just from that one principle, it's an acknowledgement of the history, and it's also an acknowledgement of how important language is and how important the words that we use to talk with each other, to talk to each other, in spoken word and written word. So that, you know, the guide says, take a look at your the action guide on that one principle. Take a look at all the things that you've put out in your community recently around COVID, around other things. What action verbs are you using? How are you talking? How are you framing these issues for your community? Have you talked ever with your community about the messages that are being received? What would it mean to co-develop some of this messaging so it's not just you and your expertise in your ivory tower? And so I think there's a real, and there are always blank lines in the action guide for institutions to learn and teach us and to teach each other different actions that might be impactful in different contexts.
Right. Did you feel like you accomplished in terms of gathering the right voices around the table? Do you feel like you were able to accomplish that? Were there areas that you wish you could do more in terms of having the right folks in the tent at the table?
So, I mean, the work is never done. You
Right.
can always be more inclusive. There are always folks that were not at the table. I know that we did a particularly focused job at geographic diversity, at including sovereign nations, and making sure there was racial, ethnic diversity, and institution type. The folks were coming from different kinds of places, which is also really important. But no, we're never done. 30, 35 people certainly don't represent like the lived experience of all communities in the US. But what I think was really instructive and where those principles came from were the overlaps, right? Were the themes that regardless of geography, regardless of who the interviewer was, regardless of that person's experience and perspective, resonated equally across those 7 places, right? Of follow through, of making sure that you are doing the hard work of community engagement and not just going to your typical partners, that you're being transparent, that you're maintaining relationships even when you don't have an ask, right? These themes were evident across all of the interviews. And so that's where we really focused the work of the toolkit.
Excellent. And this is a nice segue into the guide, into the response of the guide. We're all capable of bias. And I feel like I'd like to hear a little bit from you about how language and our words and impact bias, because there are many of us who are very sincere in the work that we're doing. And then came the guide and there were a lot of interesting, the New York Times, me and some of my colleagues were looking at that and I was like, oh no, and so it's not just, the idea that there is a guide that is helping us grow and improve, but it's also, oh my gosh, like if I've never thought about an area that had really a language of its own. And perhaps what I'm hearing and what I'm reading, it was not the right language. But even in that language, people were really struggling. Folks were talking about DEI, saying the wrong words and being attacked.
Yep.
Some people were being fired. It just shut down the conversation. And I think a lot of people saw the guide as, is this going to help the conversation?
Yes.
Or is this going to further shut the conversation down? And so I have to be honest with you. I read the critique reviews first before I got to the guide. When I got to the guide, my mind shifted. But tell me a little bit, first of all, about what the response was,
Yes.
what it was like. I'd like to hear that.
Oh my goodness. So I'm glad that your response shifted. I'm glad that yes. So I want to make it clear, like, what are the goals of the guide? I'm just going to start with what we thought, right? The AMA and the Center for Health Equity and the AAMC Center for Health Justice. The goals of the guide, I think we all thought were fairly simple and straightforward. So I'll give you 2. 1, how can we make our language, and the broadest definition of language, how can we make it more respectful, inclusive, precise, and action-oriented? So that was the goal, right? Respectful, inclusive, precise, and action-oriented. And we really thought that the way to start getting there is through reflection. So the whole guide was about reflection, your own reflection on your own, your reflection together, having those challenging conversations. So that's what we set out to do, because language does matter. And that's, particularly when the language that we use can either reinforce harmful narratives, right, or upend them. Even with the best of intentions, we can select language without thinking, just kind of off the cuff, that reinforces kind of harmful narratives. I think your question was, and I'm finally excited to get into this because I haven't really talked about some of the reaction to the guide. I think from those folks in the field doing the work, our partners, both in healthcare, public health, and beyond, because health justice is a multi-sector endeavor. I think there's been so much support. I have received many emails, phone calls saying, thank you for this. Even when we all talked, Pamela and Daniel, thank you, we're using it, we're thinking about how we might shift. And so that's been really edifying, because that's the purpose of it. It's not saying you're wrong. I think, we tried to make it very clear in the guide throughout, even in the introduction. This is not a checklist. I think much of the press missed that point, right? There are no right or wrong answers. Context matters. I think much of the response also missed that point, right? This isn't a mandate. The AMC, the AMA can't demand how physicians talk to patients. Kind of missed that point too. And then I think I'll give you a perfect example of maybe one of the more controversial pieces of this. And I think it's so important. And it's the word vulnerable. So here's the juxtaposition that I make, and then I'll get into some of the reaction. So I don't mean vulnerable in terms of susceptible, right? So if I wanted to say we all are vulnerable to the novel coronavirus, perfect, that makes sense. Why would you change the word? Okay, great. But in health equity, we don't just use the word like that, right? We talk about our work with and in and for vulnerable communities. And I think we can all see pretty clearly, when you frame it that way, a series of questions that does this, given our American narratives, right? That says, oh, vulnerable community. Well, what is that community doing to make itself vulnerable? Why doesn't that community fix itself? Why doesn't that community find the bootstraps that we assume all communities have and pull those bootstraps? So just that phrase, vulnerable community, might lead some people down that pathway of questions. So a simple change that is suggested that you might consider switching the words around a little bit to talk about communities made vulnerable. What that does is it sparks a whole different series of questions. Communities made vulnerable. By whom? Who did that? When? How? Like, what were the tools with which you made a community vulnerable? And then that's the precision, right? It's getting to the etiology of the vulnerability.
Right.
And then you get to the action piece. Well, if vulnerability is made, because there's nothing inherently vulnerable about a community, if we've made that vulnerability, then the most important question is, how do we unmake that vulnerability, right? So it's just a different series of reflections and thoughts and questions. But here's what happened, right? So in the guide itself, you instead of saying these words and vulnerables there, it says something like, you might consider, and it gives you some options. So made vulnerable is one, I think disenfranchised is another. And then there's the word oppressed, right? Which just set off across the entire political spectrum, right? So it's not just the New York Times and the Atlantic. It was also InfoWars and Newsmax. So it was kind of across the board, right? That set off a kind of a cavalcade of cherry picking, saying, well, this doesn't you would never say we are oppressed by the novel coronavirus. Well, no, we're not suggesting that you replace vulnerable in that way, because context and community matters. And I could make the argument that in 2022, I would say that our friends, neighbors, and family who identify as transgender, we could absolutely make the case that they are oppressed, politically, socially, athletically oppressed in 2022. We could talk about that. But again, context and community matters. Mm-hmm. So I think, the political right slammed it as Orwellian. I think the political left slammed it as, making sure that we lost the Virginia election and that kind of debate about W, which I can't even say the word. At the end of the day, this isn't about political correctness. It's about scientific and historical correctness. But I think it begs the larger question is, why is reflection that we've suggested, why is that so threatening, right? What might it reveal if we ask and answer these questions honestly, right? What might it ask us to do? And I think what it asks us to do is maybe start upending some of those harmful narratives and really change the status quo. And I think that's threatening for folks across the political spectrum to really do that kind of introspection about what we're really saying with our words and our intent.
You talked about harmful narratives, and a very dear friend of mine suggested that I read Whistling Vivaldi. And in that book, they talk about stigma. and how stigma impacts very bright students, that just the words, just the harmful narrative can impact performance.
Yes.
Talk to me a little bit about, I believe that was your thesis that you shared with me. Just, the power of words, I think people underestimate.
Yes.
And some people understand it very well and use it to their advantage to further polarize us and kind of, push back progress. So talk to us a little bit about stigma,
Yep.
and talk to us about how words are used very intentionally to stop this work, to stop the unfolding or peeling the onion back on definitions.
So yeah, my dissertation was actually on trust and stigma. So I feel like we could just talk all day. I think one of the interesting things that I learned from my early work in stigma is that the imperative of community engagement and really understanding the kinds of labels that are applied, right? So every community was different. So I'm a psychiatric epidemiologist trained by Social Eppies. And so a lot of my early work focused on barriers to mental health service utilization. And so my stigma work focused on the stigma of mental illness and how in white communities, the labels affixed were very different than in Chinese American communities that were very different than in African American or Caribbean American communities. And so only by doing that deep kind of community engaged work and talking with people and being brave enough to talk with people and earning that trust so the responses were honest and authentic, would you understand that mental health stigma might be completely different across communities. So the interventions would be completely different. The power of words and how people, I'll give you a perfect example. I stressed in the first couple of minutes how we hold ourselves accountable in the center for making sure that all of our equity work is about opportunity. And the reason for that, it's because it's true, but also in 2022 and 2021, I have seen a flurry of op-eds kind of against any kind of equity, all three of those flavors of equity that we talked about, right? Kind of saying that the reason that they're against equity in general is because it's un-American, because the focus of all equity efforts is to mandate equal outcomes. Right? It's not about opportunity. That's what America's about. Instead, equity is about equal outcomes. So they're taking our strength, right? They're taking the strength of health equity, social justice, and opportunity creation and being very clever to kind of turn it against, right? The actual intent and focus of the work. And so I think these conversations about what we say, what we mean, and how we align, it's really important, particularly in this hyper-polarized, very divided environment. And the last thing I'll say is that a health equity agenda is for all communities. All 100% of communities across this country can benefit from being assured they have an equal opportunity, an equal set of tools to be healthy, right? And so I think rather than dividing us, I think the goal of the center is to show how applicable this work, trustworthiness, is for all of us.
I just want to signal to the folks listening to you that we're going to, in a few minutes, we're going to shift to the chat and we're going to take some Q&As. But I did want to ask you, I wanted to go back to the question of how the guide has put fear, like people are so afraid of being politically incorrect in their language or saying the wrong things. What are your thoughts around, like, folks just really kind of fighting through the moment of fear and getting to the other side? Because if we don't get to the other side, the conversation's just shut down. And I know that's not what the guide wanted. I know that's not the results you were looking for.
No, and I've been afraid this whole time, Pamela. No, I mean, it's real. These are complicated, right? There's 100, 200 folks that don't know me that could hear and perceive and have, it is a real fear. I have been nervous this whole time, but I think it really comes back to trustworthiness, right? If I can demonstrate to you, Pamela, that I am worthy of your trust, that gives me a freedom, right, to make a mistake. It gives a freedom to you to engage in a conversation with me about how I could have phrased something differently, what I said triggered for you, what it meant to you, to build that bridge. And so I think that we have to power through that fear. The goal of the guide was exactly the kind of dialogue and self-reflection and group reflection that is uncomfortable, but is a lot less uncomfortable if it's built on that foundation of trustworthiness. And I do think there's one other really, and I know we want to get to the questions, kind of central tension in your question. You know, I remember from public health days, the nanny state argument, don't tell us what to do. I think it's similar here. Don't tell us what to think. Don't tell us what to say. We're going to do it our own way. I think there's really strong kind of impulse in our country to not want to be told what to say. But on the other hand, I think there are actually a lot of folks that desperately want to be told what to say, to take that fear away. Like, just tell me the right thing, and then just promise me that right thing is never going to change. Because I can make the shift once. And I think that's not what this work is. This, you know, whether it's health equity work, trust or trustworthiness work, it is inherently iterative. It is community and context dependent. And so it harkens back, you know, if community engagement is the foundation for all of our health equity and health justice work, trustworthiness is that cornerstone, right? And so if you're really living in fear and you're worried, have that conversation, move past that fear, ask the question, be brave in that way, and build that bridge. So.
Absolutely. And by all means, let's give each other some grace.
Yes.
And just to know, it takes a lot of strength and bravery to perhaps make a mistake. So thank you so much. And Philip, I think we need to shift over to Daniel, who's going to take some of the questions for us this afternoon. Daniel?
Thank you so much. What a great conversation. And I just want to reflect that not only is Pamela a friend, but she's also my teacher. And now I have a new teacher with Philip. So I have two wonderful teachers. I wanted to ask one question and then give it over to Robert Blake. So get ready, Robert. Let's unmute Robert. Pushback from academic medical centers that say, you know, Philip, we got enough problems operating our own, you know, we've got medical education, we've got research, and we just can't go beyond that. It's not our responsibility, and we're probably not good at it. We can't do housing, we can't do transportation. We have to stick to our knitting. What do you say? And do you get that kind of reaction from academic medical centers?
So not as often as you'd think, but when we do, I think there are a couple of answers to this. So one, the good news is there's no rush to do this work. This is a long game. You have lots of time to figure out how to ramp it up. I also want to make a note that you mentioned, Daniel, at the outset. You know, academic medicine traditionally has had three missions, right? Tripartite mission: research, clinical care, and medical education. The AAMC just about 6 or 8 months ago kind of officially added community collaborations as our fourth mission area, kind of planting that stake in the ground for our membership. And so I'd say one way to respond would also be, well, it is part of our mission as academic health centers. I also think there's a distinction between what we, the big we, not the Philip we, like what we expect individual healthcare practitioners to do versus our organizations, right? I think there are two different sets of competencies, right? For the academic health center itself as an anchor institution, as an investor, as a partner, as an advocate, and then one for individual clinicians, either in a clinical setting, in a community, in a practice. And so I think that work has just really started to begin to kind of understand and delineate what are those individual competencies. AAMC has put out some quality improvement and healthcare equity competencies, EDI competencies as well. And the centers really focus on some of those organizational competencies. How can our members be the best partners they can be in those multi-sector collaborations necessary to achieve health equity? And so it's also, we do a lot of leadership training. I'm really ready for some partnership training. So I think that's some new competencies for our organizations and our people as well.
Thank you.
Great.
Robert Blake, could you ask your question?
Sure. Thank you very much, Dr. Alberti, for your excellent chat presentation. I actually had two questions. The first one is a follow-up to your discussion with Ms. Browner-White about the pushback in the media, both by right-wing, but also some mainstream and left-wing pundits who take the language out of context and then present the mis and disinformation. What specifically is the AAMC doing to actively push back using public media whether through videos or through articles, because this has appeared in the New York Times, it's appeared on Fox News, it's even appeared in the UK, and I've been tracking these sorts of responses. So what is the strategy to counter this?
I think that is a work in progress. I think we did not want to be seen as immediately defensive. I think we all internally, there's huge support for the guide. We're using it internally. MedEd Portal is having conversations. That's our peer reviewed journal on medical education. We've had conversations with our regulatory folks about how they can incorporate this into the comment letter process and how we respond. So I think, our organizations, both the AMA and the AAMC, really stand behind this. I think we've been waiting to see just how all of this shook out. It was released late October, right before a slate of November elections, where the red herring of critical race theory and public education was really front and center. So I think lessons learned about strategic timing and when to release certain kinds of documents into the public. I do expect going forward, now that some of the initial pushback has died down, that there will be, and we've already seen one or two recently, one in Stat just the other week, some positive pieces from physicians, even from the AMC perhaps, kind of talking about why this is important, why we thought this is such a crucial document, and how we can incorporate it across all of our mission areas and activities. So stay tuned.
Thank you.
Thank you, Robert, for that question.
Can I ask the second
next
related question? No. Okay.
Go ahead, Robert. I'm sorry.
It builds on that, in that the linguist, Professor John McWhorter, has written and spoken extensively in the media about what he calls, quote, woke racism or illiberal neo-racism. And I'm wondering, how do you address the concerns that this scholar of African American studies has raised, especially as they relate to the medical and health professions context, because that's, again, picking up a lot of traction in various media.
I am not familiar enough with that work to comment intelligently, but I would love for you to share that with me, and always happy to follow up after.
Great. Okay, thank you, Robert. So the next question is, do you think there is class divisions that descend race in our society? How does it relate to your work?
If I understand the question, I think that classism and racism are inherently intertwined. It goes back to Pamela's first question, kind of MLK and how does that work continue to resonate with me and our work in the center. And I think that's true. I don't know that classism transcends racism or vice versa. I think they go hand in hand. I think they're correlated. I think they're multiplicative in their ill effects. I think they each have independent, unique impacts on health inequities and health injustice. And that's why the health justice agenda really is, and I don't mean it flippantly, like a law and policy agenda. We are not going to achieve, improved health equity outcomes for our communities, one person, one intervention at a time. Public health frameworks tell us the most effective interventions when it comes to population health are not individual education, it's not clinical intervention, it's intervention that change the context and that actually address those fundamental causes like classism and racism. And therefore it really demands that we identify kind of policy interventions. And I just don't mean federal policy, I mean federal, state, local, but importantly, organizational policy changes that with the stroke of a pen can actually shift that context for entire communities. Whether that's a class-based policy shift or a race-based policy shift, or given American dynamics, it's going to be both with one stroke of the pen, I would say.
Catherine Garrett Barrett from Boston Medical Center, could you come on and briefly talk to us about your restorative justice circles? We'd love to hear about that. We'd love to get a reaction from Philip.
Hello. Thank you for this work. So I'm vice chair of family medicine at BMC, and obviously we've been thinking about this for a long time. And one of the modalities that we've started to use to just engage in trust and historical trust, distrust in BIPOC communities is restorative justice circles. So I didn't know if you are familiar with RJ circles, if that's a methodology that AAMC has started to use, and really thinking about how do you have healthcare workers truly engaged in dialogue with those that are suffering the most, and how can we use those kinds of tools to create work moving forward?
Thank you,
I love,
Brenda.
I love the question. And so I am familiar with the methodology and the modality. I've actually seen it used in elementary schools in Oakland. I mean, just wide applicability. And it really taps into that mandate to engage and to listen and to learn and to accept that, another principle of trustworthiness, you are not the only experts, right? There is expertise all around you. So the center has not yet, we've only been open for business 3 or 4 months, I think, at this point. So we have not deployed that methodology in our community engagement arsenal. I do know that our equity, diversity, and inclusion cluster has a huge bolus of work around restorative justice. So they might be engaging in that practice and some of that work, but I'm not 100% sure. But it's such an important kind of tool in that toolkit.
Perfect. Well, I'll definitely reach out.
Please
Thank
do.
you.
We have another question from a wise man. What factors inhibit leaders of health centers from making equity-based policies to make changes on the forefront of medical care, even when they understand patients' lived experience beyond bias?
I mean, I don't want to say the answer that came to mind, but the answer that comes to, I'll say it, the answer that it's incentives and money, right? I think, medicine is still a business. At the end of the day, that is an imperative. And so, another aspect of the center's work, we talk about metrics that matter, or selfish metrics, right? So I personally, Philip Alberti, does not care so much whether what motivates you for the work is what motivates me or Pamela, that personal connection. If we can make the case that a health equity center or piece of work is going to help you do better in your value-based purchasing, let's make that case and build that evidence base. That it's going to make you make the ACGME and their clinical learning environment review visits are going to be stunned with how great you're doing in that domain. Let's focus on those metrics. So again, I think there are so many tasks at hand for your typical academic health center. So how can we, I think the onus is really on us to show that a true focus and commitment to health equity and health justice, yes, of course, at the end of the day, it's for improved patient health and community health and social justice, but there are also benefits that accrue to the clinical mission, to the bottom line, to the education mission, to our government relations, to our community and public relations. So that's a big part of our work too, is to show the multiple benefits of this agenda, not just the moral and social argument, but all of the other potential barriers in the way as well.